Good morning. Good morning, everyone, and a big welcome to today's webinar. This is an exciting morning. We will be going through the process of launching the updated guidelines for case management of COVID-19. And we're very honored to be joined by the Chief Administrative Secretary, Dr. Rashid Aman, who will do the formal launch of the guidelines. We also have with us Dr. Francis Kuria, who is the head of the Directorate of Public Health. Dr. Kuria, I hope I've not messed that up. Once we have the guidelines launched, we'll have a case presentation by Dr. Duncan Nyukuri, who is the current head of the Infectious Disease Unit, and this will be discussed by Dr. Mary Beth Maritime. So welcome, everybody. I will start off by doing a short presentation on the guidelines. But before we start, allow me to invite Dr. Kuria. I don't know if you can just say a quick word of hello.
Good morning, everyone. My name is Dr. Francis Kuria, as Dr. Lois has pointed out, and I'm glad to be part of this launch of this COVID-19 management guidelines. I hope, Lois, you can hear me.
Yes, we can hear you very clearly.
And yes, Chief Administrative Secretary Dr. Rashid Aman, appreciating your presence in this meeting today, and my fellow clinicians and colleagues. And before Lois presents the guidelines today, on behalf of the Director General of Health, it's really to appreciate all of us for having found time to join this webinar, very, very important webinar today. I noticed in a meeting that there are some of my senior colleagues, and I can see a number of my classmates, and I applaud all of them for having joined in this meeting. And my fellow clinicians from all over the counties, these are very important today for all of us as we launch these new guidelines. And we thank ourselves and go through the presentations today. It's very good also that we have been having these webinars from time to time, hearing the county perspectives of how the management of COVID-19 has baffled many over the last 1.5 years. And this then grants us a very important day when we launch this, we go back in history as what we have gone through also of the COVID-19. We all remember the onset of the pandemic when we formed the National Task Force for COVID-19. And I do recall that is when I also joined the Ministry of Health. And through the various work streams that used to work through, sometimes through the night, trying to grapple with the science and evidence that was there then. And I do recall the case management team that is with us here today. And allow me, Sir Rashid, to really appreciate this team, the case management team, for what they did in the initial stages of this pandemic, grappling through the unknowns and the sciences that were there, then the evidences from all over, and also grappling with some realities of life where some countries and jurisdictions were adopting other methods, including traditional medicine and herbs. Remember cases like the ones in Malaysia and Madagascar and stuff. And the team having to work through very hard to develop these, the initial guidelines that have guided the country so far. So today, as we launch the revised guidelines, we can only be more than proud of ourselves as we are announcing a national outlook. And these are domesticated guidelines that looks at what has happened in Kenya, that has gone through the science. And we need to appreciate all the academia in the Ministry of Health, the university staff, and anybody who has contributed to the development of these new guidelines. So allow me, sir, as Rashid, to really appreciate this team, the case management team that has really grappled through the science and come up with these revised guidelines that are going to guide how we are going to move forward in the next few days, months, and weeks. We, of course, do appreciate that this is a living guideline, is a living document. It's going to be revised from time to time based on emerging evidence. For now, and I know it's a day for all of us, is to thank that team and thank all of us for providing time to have this meeting today and launch these guidelines. I thank you, and I welcome all of us to do this meeting on behalf of the Director General. Thank you very much.
Thank you very much, Dr. Kuria. And Dr. Rashid, with your permission, if we could kindly just do a quick review, highlighting some of the areas in the guideline, then we'll invite you to go ahead and launch through Dr. Kuria. So thank you very much. I will just share my screen. So these are the case management guidelines that have been developed by a large team from the Ministry of Health, the University of Nairobi, Kenyatta National Hospital, WHO, Nairobi Hospital, and many hospitals in the counties. A large team came together to work on these guidelines, and we'll just give a very brief overview of what is covered in the guidelines. So why is it still important that we have guidelines at this point? And this is a question that's worth asking currently, because we've noted that our cases are going down. Does that mean that COVID has come to an end? What do we expect going forward? And this is a map borrowed from our World in Data, which does analysis of COVID-19 cases globally. And it's really just showing what the change in confirmed COVID cases over the last 14 days has been. And as you see, Kenya right there, we've had probably a 25% decline in cases, but there are regions in the world that are still seeing an increase in cases. And if there's anything we've learned about COVID over the last 1.5 years or so, we know that if other places are seeing a surge, we always have to prepare ourselves for whatever may come next. So even as time goes on and as our cases continue to drop, let us be careful not to drop our guard, to always be prepared and to be ready in terms of managing patients as they come in terms of prevention, in terms of encouraging vaccination and the rest. What is in the guideline? So the first part of the guideline really looks at the case definition of COVID-19. And here we go through what is a suspected case, what are the clinical criteria, what are the epidemiologic criteria. We realize that with time, as COVID becomes more widespread, epidemiologic criteria will continue to change over time. We talk about what is a patient who has severe acute respiratory illness and what is a confirmed case of SARS-CoV-2 infection. And as well in children, the issues of multi-system inflammatory syndrome, which we're seeing increasingly in children. So the first part really just goes through how do we define a case of COVID-19. Beyond that, once we identify a case of COVID-19, what is the next thing that we should do? And we really have to think around the issues of isolation, of prevention of infection and containment. And we've included a section that looks at how do we set up an isolation unit and what PPE is necessary for healthcare personnel. And this is important because as time goes on, in the beginning, we were all very terrified of COVID and we wore a lot of things to prevent. We are still terrified of COVID, but we know that with some basic PPE, we probably should be safe. So it talks about the levels of protection and what protective equipment is needed for each of these. And one of the things that will be notable in this section is that we have downgraded the role of the coverall and encouraged more of the use of an apron or a waterproof surgical gown where someone has very high level of exposure. So as time goes on, it encourages people to use less of the coveralls. They are uncomfortable to use, but they also limit the amount of care we can give to patients. So that's the other section that's included, all the issues around infection prevention in the context of COVID. The next section covers issues around testing. Testing for both asymptomatic and for symptomatic patients. That includes use of both PCR as well as a rapid test such as the antigen test, and how to handle each of the levels of testing, how to interpret negative, positive, or indeterminate tests. So that's included in a section on testing. The next section talks about triage. So a patient presents to a facility and we assume that these patients missed the case definition for a probable case. What should we do next? One, it's important that we define those who are unlikely to have COVID so that they continue to get routine care without delaying in providing essential care for patients that may need that. If we delay in providing care, then we have worse outcomes for patients who do not have COVID. So it's very important that we understand the case definition and where someone meets the case definition. The testing, as has been highlighted in the previous section, and where to take care of this patient, and where possible, home care as may be necessary. We also highlight the role of various tests such as chest imaging. And the reason this comes here is because sometimes there's too much of imaging done in patients who may present with mild disease or moderate disease, especially where it does not change what we do for the patient. So those are highlighted, as well as where to take care of the patient. So that's a section on triage. The next section for patients who are confirmed to have COVID-19 or are highly likely to have COVID-19 is how to assess for severity of disease. Assessing for severity of disease enables us to manage the patient in the right place, enables us to manage patients in the right place and to offer the right care, so that patients who have mild disease can potentially be taken care of at home. Patients who have moderate disease, again, an assessment of whether they're at risk of progression can then be done, and we determine whether they can be taken care of at home or in a facility. Then issues around severe and critical illness in patients who require hospitalized care and probably critical care. Then we go into a section of management. And here, other than just the assessment of severity, there's the issue of assessing risk for progression and identifying comorbidities, determining whether patients should be managed at home or in a facility, the necessary investigation so that we do not over-investigate patients, carrying out tests that do not change what we do for patients and drive up cost of care, but only doing those tests that are necessary. There are issues around when and how to offer oxygen therapy, issues around proning to improve oxygenation, when to use steroids, and issues of thromboprophylaxis. So throughout the book are included simple charts that can be printed out and hung up, that people can use really to quickly try and determine how to manage a patient. So this is an example of one of the charts for managing an adult patient with COVID-19, whether it's mild illness, moderate, severe, or critical illness. And as we go through the rest of the guideline, each of this is expanded on a little further. There are other things that we've included in the guideline, because over time we've noted that there's excessive use of medication that is not supported by any evidence. So this is highlighted that these are not supported by current evidence. Things like hydroxychloroquine or chloroquine, azithromycin, or other empiric antibiotic therapy, ivermectin, which you have seen a lot of use in the recent past, convalescent plasma therapy, empiric therapeutic or intermediate dose anticoagulation, aspirin, high-dose steroids, vitamin C and D, zinc, and ulinastatin. So again, for the healthcare workers, our encouragement would be that we avoid using things that are not supported by evidence. They will not be useful to the patient and may potentially be harmful. We include a section on management of children, and again follows the same sort of schema as management of adults, looking at assessing severity, determining where to take care of a child, oxygen therapy, issues around steroid use, thromboprophylaxis, and management of the multi-system inflammatory syndrome in children. So again, simple charts that will enable people to quickly follow through and could potentially be printed out and used as infographics in the facilities. There are other therapeutic agents whose use have gone up recently, and there's a section included on this just to offer guidance on when to use them. And the reason why it's important to look at the guidance is because, one, these drugs are extremely expensive, may be associated with various side effects, so we really have to determine who the right patient is that will benefit from this therapy. There's a large section on oxygen therapy. And CAS, about a month ago, we held a 5-week webinar series educating healthcare workers on oxygen therapy and providing critical care. And a lot of the things that were covered in that webinar series have now been captured in this guideline. So in which patient do we use what device to deliver oxygen, what volumes of oxygen to use for different patients, and how to monitor those patients is all captured in the guideline. When to ventilate a patient, how to ventilate, how to intubate, how to maintain the airway, and how to maintain a patient who's ventilated, what medications are required, are covered at length in the guideline, just because this is an area where there's a large gap in many facilities, especially around taking care of critically ill patients. So that's also covered in the guideline. Issues around patients who are in shock and how to offer hemodynamic support, either with fluids or vasoactive agents, is also covered in the guideline. So after the treatment comes the decision about when to discharge or to de-isolate these patients. So here we look at different criteria, such as symptom-based and time-based de-isolation, and also emphasizing that at this point, there may be no need for repeat testing prior to ending isolation once these criteria have been met. I think this has been a challenge with many healthcare workers asking about how to test patients, many employers demanding a negative test before employees can go back to work. So this should offer some guidance on that in that area. Over time, as we've managed more and more patients, we are now struggling with patients who present with post-COVID-19 symptoms, or what has previously been called long COVID. So there's a section on how to identify and manage symptoms after acute illness. Many facilities may now be setting up clinics for post-COVID patients, and there's some guidance offered in that area. Vaccination is also brought in, and this aims to answer some of the frequently asked questions. Who should get the vaccine? When should vaccination be given after someone has had COVID-19 disease? And what happens if someone develops COVID-19 after vaccination? And this would be an important area. This chart here is actually borrowed from the CITREPS that was released yesterday. And we still have a large number of people who've not yet received their second vaccine. So fully vaccinated population in the country is just about 3.4 to 3.5%. And of those who've received the first dose, only about 31.5% have received the second dose. So hoping to answer some of the common questions and dispel some of the myths around vaccination so that we can encourage our patients and our populations to get vaccination. There are a few things that are not yet included, but we look forward to including even as we update these guidelines over time. And one is newer therapies that may not yet be available in country, such as monoclonal antibodies for both prophylaxis and for treatment, and newer antiviral agents, such as molnupiravir, which has been in the news a lot over the last few days. And I just included 2 slides on it because a lot of people have asked the questions about this. So basically, it inhibits replication of the RNA. So with that, if it's inhibiting by incorporating sort of the wrong molecules in there, then the virus cannot replicate. And a number of studies have shown that, especially in the older patients, molnupiravir results in a much reduced incidence of hospitalization or death and the rest. So it may be particularly useful in older patients. So these are things that we look forward to including as time goes on. So that brings us to the end of what's included in the guideline. And there's a very large team that was involved in the development of these guidelines, and I've included all the people here from very many different organizations around the country. And we thank all of them for the time given towards this guideline. The World Health Organization supported many of the writing meetings and the stakeholder engagement meetings, and they're currently supporting printing of several copies that will be distributed around the country. We also acknowledge the University of Nairobi, where many of us come from, and the Kenyatta National Hospital. Thank you very much, CAS. So Dr. Kuri, I'll hand over to you again so that you can invite the Chief Administrative Secretary.
Well, thanks again, thanks a lot, Lois, and thanks for taking that part of acknowledging the participants and the contributors to the development of these guidelines. We cannot thank them more, and especially more our support from WHO and other partners have really supported the development of these guidelines. For the sake of time, and maybe there is one item that is also not highlighted in the guidelines that keeps coming to us on our desks here, is about the issue of the movement of those who have recovered from COVID-19. And we've had to write several approvals to allow people who have recovered from COVID-19 to travel back either into the country or out of the country. I guess that is also not covered in the guidelines, but as I said, this is a living document to be addressed and to be revised from time to time to address some of such gaps as the issues of traveling for those who have recovered from COVID-19. There'll be, of course, others that are going to come up later, like the issues of antibody levels of the recovered from COVID-19, and for how long the vaccine does protect people. These will come later in the revised guidelines as we go along. Allow me then at this juncture to take this opportunity and my humble duty then, therefore, to invite the Chief Administrative Secretary, Dr. Rashid Aman, to address us and give a few remarks and officially launch these guidelines as we move to the next part of the program. Welcome, sir, Dr. Rashid Aman. Thank you very much.
Thank you very much, Dr. Kuria, and thank you, Lois, for the wonderful presentation that summarizes what your guidelines is all about. Good morning, ladies and gentlemen. I'm happy to note that we have over 614 participants who are following this presentation. Good morning once again to the panelists as well as those who are participating in the webinar. Today marks 574 days since we recorded our first case of COVID-19 in Kenya. This global public health emergency has been a severe test and strain on our country's health systems and preparedness to counter a pandemic. To date, we have recorded over 250,000 confirmed cases and over 5,000 deaths, unfortunately. May the souls of those who died rest in peace, amongst whom are 50 healthcare workers. COVID-19 has changed our world. Adversity brings out both the best and the worst in humanity. We have witnessed the COVID-19 pandemic rally people, communities, and nations together, but also drive them apart. While our world has been changed by the pandemic, the fundamental response pillars of leadership, informing, engaging, and listening to communities have not, I believe. The Ministry of Health fully embraces the spirit of teamwork and unity of purpose. Very early into the pandemic, the ministry constituted the multidisciplinary and multi-stakeholder National COVID-19 Task Force, which has been a guiding force of the country's response. Its various technical working groups on testing, case management, risk communication, and community engagement, among others, have been instrumental in shaping the country's response efforts. You will agree that case management of COVID-19 has been evolving with progression of the pandemic as learnings on this new disease have emerged. In April 2020, we deployed our first COVID-19 case management guidelines and conducted rapid training of healthcare workers on diagnosis and treatment of COVID-19 to quickly build up the HRH capacity, even as counties prepared themselves by setting up isolation centers and stocking on supplies. We have indeed learned a great deal in the course of managing the pandemic. Our healthcare workers are now armed with more knowledge on COVID-19. They have learned who is at risk for severe COVID-19, what treatment works, and what doesn't. We know which public health measures we need to focus on in order to combat the pandemic, and also have a few more shields in our armament, such as the COVID-19 vaccines. We also recognize that improving quality of care requires guidelines that are evidence-based and aimed at achieving favorable outcomes for our patients. We have learned an enormous amount, and we are still learning. This disease still baffles even the brightest of the brightest. But with our research team, we shall always be on the lookout that Kenyans get the best care available to them. I commend our healthcare workers for being on the front line, even when we did not know anything of this new disease. Special recognition to the team led by Dr. Lois Ombajo on case management, on coming up with the initial response guidelines that have brought us this far. This has been a collaborative effort, bringing together health workers from all sectors, our universities, private and government facilities managing COVID-19 clients, to determine and institute the best practices in their management. I believe that these guidelines are a product of our learnings and reflect our contextual experience with COVID-19. This technical team has combed through recent research and together with the academia have produced an evidence-based guideline on treatment of COVID-19. And I want to commend them for this excellent work, which brings together experiences throughout the globe, but more importantly, incorporates our own experiences in our own environment. These revised guidelines provide updated recommendations on the following areas of COVID-19 management: case definition, infection prevention and control, diagnosis, stratification of patients according to severity of illness, management of asymptomatic, mild, severe, and critical illness, management of comorbidities, such as diabetes in the context of COVID-19, discharge and de-isolation, management of post-acute COVID illness, which is something we will have to deal in going forward, as well as issues related to COVID-19 vaccination. We do recognize that indeed this is a living document and will be updated from time to time as more knowledge, data, and evidence becomes available. We know that the management of COVID-19 disease has often been individualized by some clinicians. Some clinicians have gone on air and recommended all manner of treatment regimens which may or may not have worked. Our patients have also sought all manner of treatment out of desperation, ranging from over-the-counter treatment, alternative medicine, and even unconventional, traditional, and herbal medications. Regrettably, the outcome of some of these treatments have been disastrous, leading to severe complications and at times even unnecessary deaths. In order to have a standardized approach in the management of COVID-19 disease in the country, I call on all healthcare workers in the counties and in the country at large to adopt, implement, and adhere to these revised guidelines for the clinical management of suspected or confirmed COVID-19 patients, as it will lead to better outcomes for our patients and avoid unnecessary mortalities. Members of the public are also strongly advised against self-medication and use of over-the-counter medicines for treatment of respiratory tract infections, and are advised to seek medical attention from qualified healthcare workers. And science, which is the basis of facts in the fight against disease, tells us that the vaccine provides greater protections against severe disease in the event of COVID-19 infection. The government has therefore prioritized vaccination as one of the key measures to contain the spread of COVID-19 to achieve adequate coverage, and following WHO recommendations, Kenya needs to vaccinate the entire adult population, accounting for about 30 million Kenyans, or 60% of our population by the end of next year, 2022. In order to achieve this ambitious target, the government has resolved to accelerate our vaccination program across the country so that we vaccinate as many Kenyans as quickly as possible with the aim of attaining herd immunity. Among our new strategies are targeted outreaches and awareness campaigns and increased social mobilization. I am calling upon all healthcare workers to fully engage communities around us, be champions to debunk the misinformation on vaccines that is slowing down the progress on vaccination, and champion this humble call to vaccinate as many Kenyans as we can. To conclude, we must also not forget that all these efforts are championed to improve the health of our people. To the clinicians, I give my immense gratitude and encourage you to give the best to your clients and that you do not make an enemy of them. Ladies and gentlemen, it is now my utmost pleasure and humble duty to launch these revised COVID-19 Case Management Guidelines 2021. Thank you. I submit.
Thank you very much, Chief Administrative Secretary Rashid Aman, for those advice council and very kind ones to all of us and very encouraging remarks, and of course calling us to action as healthcare workers to really embrace these case management guidelines and more so be champions. I recall in my opening remarks that I see my senior colleagues, former classmates, and very many clinicians on this forum. Like I said, 698 of us. So the call from you, Kas Rashid, goes a long way in implementing, in calling all of us to be champions. And more so as we go, as we head towards Mashujadi, we want to count all of us to be counted as Shujas. So we hope that all of us will hit the call, but we go out as champions and mobilize communities around us, more so so they can increase the COVID-19 vaccine uptake. So thank you very much, Kas Rashid. And with those few remarks, let me hand over back to Lois so that we can then go through the rest part of the program. And thank you very much again for participating in this forum. God bless you, sir.
Thank you so much, Dr. Kuria. Please allow me to invite Dr. Kamuri, our CEO, who's also on the forum, to say hello and just give a quick vote of thanks. Dr. Kamuri, karibu sana.
Asante sana, Lois and colleagues, Waziri and Kuria. Good morning, all. I don't have much to say as per the protocol. Once Waziri talks, I may not say much, but I want to say my sincere thanks to the team for assembling these guidelines. This is like a constitution for management of COVID. And I know the amount of work that the team has really put. Well, I sincerely thank on behalf of the hospital and the board, and encourage them that, as Kuria has said, let us all be ambassadors. Let us preach the gospel. COVID is still here with us. Secondly, I want to thank the clinicians who have really dedicated themselves in taking care of our patients and also holding on the hospital in managing our COVID patients. I really, truly, you are our heroes, and we'll continue lifting your names up because it has been pure dedication. However, lastly, there are still people who are not yet vaccinated, especially a group of nurses and a few doctors. If you have any friend who is not vaccinated and actually you know, please encourage them. This is the only way we can be able to actually handle COVID in an easier way than and reduce the mortality. Otherwise, I will thank you, Lois, and your team for really making this thing happen. And God bless you all. Thank you.
Thank you, Dr. Kamuri.
Well, if I may step in and just first of all, request to be excused. Discussing these important management. You can see you have a great audience growing now, 715 participants. So I wish you the best. And once again, we reiterate that the ministry is fully behind supporting all the initiatives that you have undertaken in the response on COVID-19. Thank you. I hope I'll be allowed to exit now. Okay, thank you.
Yes, sir, you may exit now. We will proceed from there. And thank you very much again for joining us in this forum. Lois, over to you.
Thank you so much, Dr. Kuria. I think we also acknowledge the presence of other senior MOH members. Dr. Kibias, thank you very much for joining and for supporting this forum very many times. The members from the World Health Organization, we really acknowledge your presence as well. Many people have asked how they can access the guideline. I have posted it in the chat box, so you should be able to open. Please share it out with as many healthcare workers as possible. The printed copies will be released very soon, and I'm sure all the facilities will get some copies. Thank you very much. I now hand over to Dr. Nyukuri, who will take us through the case presentation.
Maybe Lois, before you hand over to Dr. Nyukuri, allow me to present the apologies from the Director General of Health, Dr. Patrick Amoth, who has been traveled out of the country. And I stand here on behalf of the Director General. So in his absence, feel that he's still present with us and he gives us his greetings. Thank you very much.
Thank you, Dr. Kuria. And thank you for your time and for representing him as well. Dr. Nyukuri, please go ahead.
Thank you, Dr. Lois. Okay, so I'll present a case of a patient who managed in the last months, which we will use as a learning point and on how to manage COVID-19 using the guidelines that we have developed. Okay, so patient's name is VNM, a female, 73 years old, was admitted on 9th of August 2021 and discharged on 17th of September. So she was with us for more than a month. Non-hypertensive patient on Amloza. She was a referral from a peripheral facility for ICU care. And at presentation, she complained of a cough, difficulty in breathing, and chest pains for 1 week. At the peripheral facility, a rapid antigen for COVID-19 was positive. An examination findings with the lady was sick looking, obvious respiratory distress, and of note also she had central obesity. Airway, she was speaking in interrupted sentences. Breathing, you can see she was saturating at between 34 to 40 on room air and 70 to 75% on 15 liters non-rebreather mask. So we switched her to a high flow nasal cannula, a flow rate of 40 liters per minute, FiO2 of 100, together with 15 liters NRM. And she improved, and SpO2 rose to 97%. Circulation, her BP was 139/111 with a heart rate of 82. Blood gas at that time, she had decreased oxygen and also decreased bicarb at 17%. So management, we maintained a high flow nasal cannula at the current settings, that baseline labs and COVID PCR. Also did a CTPA with lung window. Meds, she was put on Baricetinib, which she was on from referring facility, dexamethasone, Xen, treatment doses, paracetamol, and to continue with antihypertensives. So we got the labs later in the day. CBC of note was slightly elevated WBC at 10, with a neutrophil count of 8.25. HB was normal, and so were the platelets. The D-dimers were elevated at 1,311, and you can see the control is 353. With PCR was positive. Blood sugar was 10.6. HbA1c was 8.3 with a normal UND. We continued basically with the current management after we got these lab results. 1 day later, we noticed that the patient was deteriorating. SpO2 had dropped to 85. Now we are at 70 liters per minute high flow nasal cannula at an FiO2 of 100. Also was now becoming asymptomatic with the pH of 7.3. PO2 was low at 5.2, and also PCO2 was low at 4.9. RBS now had gone up to 16.9. We wanted to do a CRP, but unfortunately at that time we didn't have reagents. So we made a decision to change to IV CPAP with a PEEP of 8, a support of 10, and a FiO2 of 100. Managed to increase the SpO2 to 93/95. She was also started on soluble and Lantus insulin. The Baricetinib was stopped, and she was started on tocilizumab at 800 milligrams. So subsequently, the patient improved. The improvement was gradual over the days, so I really didn't put all that. 9 days later, as you can see, there was improvement with decreasing oxygen and pressure support. We changed her to non-rebreather mask at 15 liters. The next day, she had improved. She was on nasal prongs. We managed to get a CTPA with a lung window. A CORAD score was 24/25 with subpleural burns and septal thickening, but no PE. So we dropped the Lexen to the prophylactic dose. At that time, we repeated a COVID PCR, which was negative. So we transferred her to the ICU, and then she was stepped down to the ward. The sugars were well controlled, and we were able to change to oral metformin. So subsequently, she continued to require low dose, low oxygen levels at around 5 liters nasal prongs. At that point, a diagnosis of COVID fibrosis was made. She was initiated on pirfenidone, 200 milligrams, and also intensive spirometry. Around a month plus after admission, she still required low-dose oxygen, low levels of oxygen, saturating at 5% of oxygen and 93% on 3 liters. She was discharged with an oxygen concentrator, but followed up in our infectious disease clinic and the chest clinic. Good news I can report, I saw her today. It was a clinic day. She's doing well. She's off oxygen. Still requires some support walking, but otherwise she has really improved. So I'd like to hand over to Dr. Mariti to take over and just discuss the case on what we did well, what we could have improved. Yes, Dr. Mariti, over to you. Thank you.
Good morning, everybody. Thank you so much, Dr. Nyukuri, for that excellent case. And it's good that our patient did well on the treatment. And we really wanted to use this case to highlight several aspects that we've included in the national guidelines that Lois has given us an overview about. So this patient basically represents quite a number of patients that we see in our facilities. And I think most of the things that you did for this patient are really appropriate and as per the guidelines that have just been highlighted. And I know we'll have different case presentations going forward to highlight various parts of the guidelines. So initially when the patient came, like you clearly said, was referred from a peripheral facility, was already deteriorating. And the most important thing was that this patient had just had an illness of about 1 week and therefore was rapidly progressing, because traditionally in the past, I think before we had the Delta variant, patients used to present the first 1 week, they're just having upper respiratory tract findings. The second week, maybe they go into lower respiratory tract findings. But this patient within a week of presentation had fairly rapid clinical course. And some of the risk factors that you've highlighted, patient was hypertensive, she was elderly, and then she was also obese on the clinical examination. And maybe those are some of the things that contributed to the rapid progression. An important thing to ask our patients increasingly as we go through the pandemic is to take history of vaccination or prior vaccination. And this patient was not actually vaccinated, despite the fact that at that time our guidelines recommended that patients older than 60 years were in the priority group for vaccination. And the fact that she also had a comorbidity means that she had a lost opportunity to present earlier for vaccination, which could have averted the severe illness. When the patient presented, the first thing you have to do for the patient is to triage them. And this patient fell into the severe illness. And clearly on our guidelines on page 25, we have a very good chart on illustrating how to triage the patient, so that a patient who has features of pneumonia, which is tachypnea and a respiratory rate more than 30 and oxygen saturations less than 94 would qualify as severe illness. At the point of presentation, we couldn't identify features of severe illness. at that particular point in time. She wasn't really in shock. She wasn't having organ dysfunction at that presentation. So she would qualify as severe illness, but her saturations were very, very low. They were 34 to 40% on room air, and increased slightly to 70 to 75%, which is still below the required threshold. And this was on 15 liters of non-rebreather mask. And that's why the patient was promptly put on high flow nasal cannula, which stabilized her oxygen saturation. But we can see within a day, the patient started declining again. And that's why the patient now had to be supported through non-invasive ventilation. We've had several sessions before that were highlighted by Lois, and those sessions, for those of you who might have missed the 5 sessions on oxygen therapy, they're actually available on the KNH website. You can actually watch them on YouTube, and we had a very good presentation. In the guidelines, we actually have several pages that are dedicated to oxygen therapy, how to triage the patient, how to see that your patient is actually going down, and how to support them, and how to escalate the oxygen therapy interventions that are within reach, so that you can make sure that your patient is supported and that they don't crash. And I know many facilities all over Kenya are being supported, and they have, some of them we've even seen have received oxygen reservoir tanks that are very important, because oxygen is one of the cornerstones for supporting the patients when they have severe illness. So in this particular patient, despite the support provided, the patient had a rapid decline. And we can see on day 10, despite the high flow nasal cannula, the oxygen saturation declined from the previous 93 to 95, now started going down. And that's why the patient was reevaluated. Patient was becoming acidotic, then was reevaluated. And remember, this patient had come from a previous, a lower level facility, had been receiving Baricetinib. So Baricetinib is one of the therapeutic interventions that has been recommended for use in certain categories of patients. However, it's very costly. It belongs to a class of agents that's called Janus kinase 1 and 2 inhibitors. It's fairly costly. It has been used before for treatment of rheumatoid arthritis and has been repurposed, and clinical trials have actually shown that it's beneficial in certain groups of patients who deteriorate when they are already receiving oxygen. So it's recommended for use in addition to steroid use, which our preferred steroid is dexamethasone. So you can add on Baricetinib. And this patient was already on Baricetinib in the referring hospital, was already on 4 milligrams. It's recommended to give it over 14 days, which is very costly on each of the days. And that's why, because of the clinical deterioration, it was decided to substitute it with tocilizumab, which is a monoclonal antibody that has been also found useful. And in the guidelines, in the current treatment guidelines that we are rolling out, it may be indicated for patients who have a clinical deterioration when they're already receiving oxygen and are already on dexamethasone. But you only use it in patients where you can demonstrate the clinical decline and elevation of inflammatory markers, in this case CRP, which was requested but was not able to be done. And the patient received a start dose. So unlike Baricetinib, which you use over 14 days, tocilizumab, which is given as a start dose, is still fairly expensive, and patients have to buy it on their own. So it may be useful in certain patient categories, but you have to identify the right patients, and you have to make the decision fairly early, supported by the clinical deterioration of the patient, in support also with the clinical markers. And this patient responded fairly well to the tocilizumab that was given. We've had other patients presented in prior webinars, like I think some of the patients who received it in pregnancy. Some patients have done well, some patients may not have done well, but also it's related really to the timing. And it may also be contributed by patient-specific markers that we may not know at this point in time. And we can see within a period of about 9 to 10 days, there was actually a turnaround within this patient, and the patient improved. So well done. The other thing I wanted to make a point of, this patient, I think in many cases that we've had on this webinar, people give antibiotic therapy, and then they go and try to justify the reason for use of antibiotic therapy. And I really want to commend Dr. Nyukuri and team, because we don't see use of antibiotic in this patient. Very well done. we see the neutrophil count initially was about 10.3, which is really within the normal limits. Not the, sorry, the white cell count, the WBC count was about 10.3. We see also a relative neutrophilia of about 8.25, which is around 8,250 neutrophils. Normal neutrophil count is up to 7,000. So some people who are of the pro-antibiotic use would have justified and said, oh, but the neutrophil was slightly elevated. It was more than 7,000 and we could justify use of antibiotic. But in this patient, there was no other clinical deterioration to support presence of, for example, maybe a hospital-acquired pneumonia or something else. We already had a primary diagnosis of COVID pneumonia for which we could not really justify antibiotics. It's a very tight decision to withhold antibiotics, but I really want to commend Dr. Nyukuri and team, because part of rolling out these guidelines is really to even ensure antibiotic stewardship and to only use antibiotics in patients where you can actually prove that the decline in the patient can be attributed to a bacterial super infection, which in this case we do not have any evidence of. So the patient had a turnaround time, clinically improved, initially had been on treatment doses of Clexane, where was receiving 60 milligrams twice a day. And in the guidelines, actually we have a specific algorithm that will make big printouts and hang in facilities as a job aid, because we have different categories of patients. And one of the recommendations is that for most of the patients, they would require, if they're coming to be admitted, they would require prophylactic doses of anticoagulant therapy. But in cases where you have a high risk or high index of suspicion for potential presence of, for example, pulmonary VTE of venous thromboembolism, then you can justify using treatment doses. In our patient, the D-dimers were markedly elevated. The patient was very sick. We were not able to do the CTPA earlier on, and therefore the patient was put on treatment doses of Clexane. But once we did the CTPA much later on in the treatment, and it ruled out any venous thromboembolism or pulmonary thromboembolism, then the Clexane was reduced to prophylactic doses. But also the importance of the CT scan was to identify for us any other potential complications in the chest, and clearly picked for us that the patient had evidence of pulmonary fibrosis, evidenced by the subpleural bands and septal thickening, but there was no pulmonary embolism that was identified, and that's why the patient then received prophylactic. Patients develop pulmonary long-term complications, including pulmonary fibrosis. This is a new, fairly new complication that is very difficult to manage, and there's ongoing work. And this patient received one of the drugs. It's called pifenidone, which has been tried for idiopathic pulmonary fibrosis. We don't have clinical trial evidence that it really works in patients who have pulmonary fibrosis post-COVID, but this patient is currently receiving this therapy and other supportive therapy, because this pulmonary fibrosis is a long-term complication that eventually may lead to other complications like copulmonale thereafter. So the patient is receiving ongoing supportive care for that, including incentive spirometry and other rehabilitation in the pulmonary system, and is oxygen dependent using a concentrator at home, and is receiving follow-up in the ID and chest clinic. So there may be a number of these patients who have long-term complications, and we included a chapter in the guidelines for what to do for these patients. And that's an area where the evidence would be evolving, and we may need to revise based on additional data that would be coming in. So just to summarize some of the important pages of the guidelines as you interact with the guidelines, and Dr. Lois had a very good summary. This case, basically, you can find reference points for different attempts or different approaches to management. So the first part, which is talking about severity of illness and classification, we have it on page 25 for the adults and page 26 for the pediatric, because that's the entry point. You need to know what's the severity of the illness in your patient, and then assess the different care pathways based on the severity of illness. So that's one of the entry points. Every time you have your patient, you have to assess. And then still linked to severity of illness, there may be patients who come in with mild illness, but they have underlying comorbidities. And therefore, you have to keep in mind that their illness may progress. And therefore, you need to take a very good history of what are these already known factors that can make the patient to deteriorate. And this, again, is provided for in the guidelines. On page 27 and 28, we have very clear different pathways for patients. So we have a pathway for patients who will be on home-based care. And we also have the home-based care guidelines that would support a lot of patients who have asymptomatic illness and mild illness. Patients who have moderate illness, if they have underlying comorbidities, then may progress to severe and thereafter to critical illness. So we have provided different pathways for the care of those patients. And part of the initial thing I cannot overemphasize, you have to assess the severity of illness at the point of initial contact with the patient. Even if the patient presented to a facility where they only offer testing, you have to provide enough information for the patient so that should anything happen, they can know how to enter the different pathways of care, particularly that may require hospitalization. Page 29 talks about therapeutics. And like Lois has mentioned, I know this is, there has been a lot of potential therapies that people are using out there, and they try to justify the use of those therapeutics. So in the guidelines, we've actually included a list in red of what not to use. So please make sure you look at that specific page, because we don't have any evidence at this point in time to support some of those therapeutics that may be prescribed in the outpatient setting. And then page 31 and 32, again, is the management focusing on the highlights of how to manage a patient, depending on the different pathways. And then thereafter, we have different pages dedicated to oxygen therapy. And this is really important for many of you who come from different facilities, because it helps you to, it has a lot of, it's very reader friendly, has a lot of images that helps you to choose the right modality of oxygen. What do I say? How to give the oxygen to the patient, and even the different flow rates. And you can, this is supplemented by the webinars that already have been held on this forum. And then towards the end, we have the section on vaccination, we have the section on post-COVID care, and the section of de-isolation, which our patient, we can see we did a test because we needed to move the patient from ICU to the ward. So we transferred the patient after the negative test, but this patient remained in the ward for a fairly long time. So most likely at the time of discharge even, the test would have been negative. We have some few patients who might persist with a positive test if they have underlying immunosuppression, which was not the case in our patient. So I'd like to hand back to Lois, but that's just a summary. Well done to Dr. Nyukuri and team, because your case typifies what we really expect, where you're complying to the guidelines and minimizing the use of antibiotics so that we can protect our antibiotics. Thank you very much.
Thank you, Dr. Martin. Excellent discussion. And Dr. Nyukuri, an excellent presentation that really highlights the various things we need to consider. And as we're doing this presentation, someone sent a message and said, if only their family member had been managed according to what you presented today, because their patient presented very similarly to the patient you presented, but they lost 2 members of a family because of mismanagement. So please, let's try to adhere to guidelines. Let's give the patients the best care we can give, and let our patients have excellent outcomes. Remember, there's always support if you need help. If you are stuck, please feel free to reach out. There are many members of the team who are happy to support you as you go through the patients. And I just saw something that someone had posted on WhatsApp, and I think it's from the Ministry of Health, and they're talking about taking care of mental health, taking care of your mental health, of mental health of people around you. So take care of yourself even as you take care of patients. Today we finish early. We have posted the guideline. We've also posted a link to the Ministry of Health website where the guidelines have been hosted already. They've already been posted there. Sorry? Oh yeah, there was Q&A. My apologies. We've done the guideline, now we want to run away. Sorry. So please feel free to post any questions you may have. Let me see if there are any questions that I'll send you. So this one I sent to Dr. Nyukuri. So someone says, ivermectin, people, I don't know what ivermectin did to people. The people really like it. But what is your comment on ivermectin, Dr. Nyukuri?
Ivermectin is a hot potato, something that we keep juggling every day. But as we have highlighted on the guidelines, there's no current evidence that really supports the use of ivermectin in the management of COVID-19. And in the guidelines, we really do not recommend it as one of the drugs to be used in the treatment of COVID-19. Yes, I'll stop at that.
Thank you very much, Dr. Nyukuri. So remember what we highlighted earlier, that this is, the word living document sounds nice, like it's growing fat a little, tall a little, occasionally losing weight, but it will change as more evidence becomes available. So the thing about always ensuring we're on the edge of providing excellent patient care is that we're also always reading, always reviewing evidence, always reviewing our own patient care and outcomes. So even in the facilities, let us be careful to audit our patient care, to audit how our patients are doing, so that we are always improving. That will be critical. I have one other question that I'll pose to Dr. Maritim in a minute, but I think I would also like to acknowledge the presence of Dr. Rwasa. He is represented by Dr. Daisy Korir, and the MTRH team has been very supportive and has participated in the development of our guidelines. So Dr. Korir, please pass our very best regards to Dr. Rwasa as well. Dr. Maritim, there's a question here about, it's something to do with vaccination. And this has been coming up a lot. I got this one, but now the one I got is not available. Do I get a different second dose? How long do I wait if my original one is not there? Is it okay if I wait 3 months or 4 months? What did you have to say about that?
So thank you, Lois, for that question. I think it's been a very frequently asked questions about vaccine mix and match and the second dosing. So the Ministry of Health currently in the deployment plan does not support the vaccine mix and match. Out there, globally, we have evidence to support mix and match. There have been studies in Spain, there have been the COP studies in the UK that actually support mix and match for certain vaccine types, particularly AstraZeneca vaccine and Pfizer vaccine, AstraZeneca vaccine with the Moderna vaccine. I think those ones, the studies are going on, but the one that we have clearly a lot of evidence is a first dose of AstraZeneca and a subsequent dose of Pfizer vaccine, where the vaccines have been shown to be efficacious and as well as safe to mix and match, and the immune response are comparable to the other findings from where you use the same first and second dose. Having said that, and this is because I'm in almost constant communication with the vaccine program, I was asking the other day whether we actually have AstraZeneca, because a lot of people who, when they're asking about the mix and match, they received a first dose of AstraZeneca and they are concerned whether they can go for a second dose of Moderna or a second dose of maybe J&J. That one has not even been asked. Many people who ask for J&J ask for J&J specifically because they're asking for, they want to receive a vaccine that's one dose. I've been assured that there are enough doses of AstraZeneca for people who are receiving second dose. So currently, AstraZeneca is not being given as a first dose, but there are enough doses for people who received it as a first dose to go for their second dose. So the issue of mixing and matching at that point then does not arise. The Moderna vaccine was introduced, I think maybe about a month or maybe about maybe 6 weeks ago. And for that one, it's been given in select facilities. And it's given as 2 doses with a 21-day interval between the doses. So that one, I think the doses are still enough for first and second dose. So just to summarize, the science is there, but the vaccine deployment guidelines by the ministry are not supporting mix and match. So I just encourage people to find out facilities, and maybe we'll identify maybe there are certain groups that are supporting vaccine deployment, and I know SEMA, University of Nairobi, is one such, which is actually trying to list facilities that have different vaccines. So we would be able to share that detail with people who may be delaying to receive their second dose, because they don't know where to go for their second dose. So at this point in time, we are not mixing and matching vaccines, but we should be able to guide you to see which facilities you can go for your second dose if you received the first dose of a certain vaccine that is proving difficult to receive. Thank you.
Thank you so much, Dr. Maritim. And maybe one of the things that we also need to remind people, during this period of COVID-19, a lot of people have set up some small health facilities. Everybody was trying to take care of COVID patients. Let's be, I'm looking for the right words to say this, but let's look out for these small health facilities. Let us support them so that they provide the right care, because sometimes this goes on and they may not necessarily provide the right care. So if you have facilities near you, please support them, share the guidelines with them, okay? So that's one. There's a comment about if we could include care of pregnant women. That is very well taken. Over the last 3 weeks, we've actually had the webinar series has included care of pregnant women. And we'll have another 2 sessions on care of pregnant women, and probably will release a short guidance on this. Dr. Rosie is here with us and she'll support that so that we release a short guidance on that. My teacher and mentor is also here, Professor Ogola. Thank you so much for incredible support that you've given us throughout this period. And the question is, Dr. Nikori, I don't know if you want to take this one. The issue of, we put full dose anticoagulation on the not to do list. Was there some evidence that it is useful in moderate disease? What are your thoughts on that?
So there was a recent study, I remember seeing it somewhere, I just can't quote it, which did not show any benefit of full anticoagulation as compared to a standard prophylactic anticoagulation in patients with COVID-19, both with mild, moderate, and even critical illness. So I think the only time where we may consider a full anticoagulation is if you have a high suspicion of a PE or DVT. So this is a patient probably who has high D-dimers, there's a proven DVT, there's a rapid deterioration, and you really cannot pinpoint as you're trying to do investigations. Then you may justify empiric before you get the final results. And that is what we did in these patients. These are patients who had high D-dimers, who had sudden deterioration, and we did not have a CTPA to roll out at PE at that point. And that's why we started anticoag as we are ruling out a PE. But in most patients, the prophylactic anticoagulation will suffice. Thank you.
Thank you very much, Dr. Nyukuri. Again, at this point, whether we give moderate dose, high dose, full dose, hasn't quite been shown to change outcomes. But having said that, remember, we manage the patient, even though we have the guidance. So where you have a patient in whom there's high suspicion for PE, where you're able to do a CTPA, that would be useful. And in patients who have evidence of coagulation, DVT, PE, and others, then we treat them with a full dose anticoagulation as per the treatment of DVT guidelines. There are many other questions. Again, some of them touch on vaccination. So I'll come back to you, Dr. Maritim. So one, this again is from our teacher, Professor Chokwe, and you're asking about the people who have had J&J. Are they also being counted as part of the statistics of people waiting second dose? That's a really good question. I think the issue is access to vaccine data is still not very good to many of us who are doing some of the analytics. So hopefully the ministry can support access to the vaccine data so that you're able to do better analytics and see exactly who's counted where. But yes, if someone has had J&J, they should be counted as fully vaccinated. Then there's a question about if someone got Sinovac. You know, in the beginning, the people who went, they were ahead of the times. They went and they got the first vaccine. And now they're here and they can't go back. what should happen? I don't know if Sinovac has now, one of those has come into the country, but that's the question someone is asking. They've had this vaccine elsewhere, and now it's not available here. What do they do? Should they just consider getting whatever is available? Should they start a whole fresh vaccine schedule? The guys who couldn't get the initial vaccine, so they went and said, I've never been vaccinated, and they got a fresh schedule. So those are, I think there are a number of questions that are sort of touching on that.
So thank you, Lois, for that question, which I may not have a comprehensive answer. And I think what I like about these questions is that they're actually giving us opportunities for future webinars. And we'll have probably plan a webinar where we discuss all these vaccine issues, because today we were focusing on the guidelines, and I know vaccine every day people want. So we use the question as a learning opportunity. So Sinovac vaccine is not one of the vaccines that's available in country. I think I heard from the vaccine deployment task force that is Sinopharm vaccine that is available, and I'm not even sure which facilities are offering it. What I understand is that for you to travel to China, you must receive one of either Sinovac or Sinopharm, but the one that's available in our country would be Sinopharm. So Sinovac, unlike the other vaccines that we have discussed previously on this webinar, is an inactivated COVID-19 vaccine. So the vaccine technology is slightly different from the other vaccine. It's one of the vaccines that has received approval, I think, from the WHO SAGE for use. The only challenge with some of the vaccines is you must have storage requirements. You must meet storage requirements and other things for them to be available. And also, some of the vaccines that were previously available through the COVAX mechanisms were easier to administer. And the ones that were prioritized were the ones that received the SAGE approval much earlier on. So as new vaccine candidates come in, then we have to set up the infrastructure to have them deployed. So currently it's not one of the vaccines that is available in country. In terms of potential for mix and matching of these different vaccines, for example, if someone receives Sinovac and now you want to recommend them to receive, for example, AstraZeneca or another vaccine type, we may not have evidence from clinical trials. And it may be that we just need to read the science behind the vaccines to see what can be the potential safety concerns or even efficacy concerns between restarting a new schedule entirely with a different vaccines. What are the potential? How will they interact within the same person who had the previous vaccine? And also, what may be potentially the recommended dosing interval between that prior vaccination with a dose, an incomplete schedule of Sinovac, and then a repeat dose of another, or starting a new schedule. So I would not have the answers at this point in time. I may not even have a place where I can send the person, but what we would need to look for is the evidence to see, particularly in settings, because these vaccines, both of them come from China, to see if they've done clinical trials to see if someone can get a first dose of Sinovac and then maybe a second dose of Sinopharm, because sometimes the vaccines that share potentially the technology may be more compatible than starting an entire schedule. So unfortunately, I don't have a very good answer for that, but I'll include it in next week's discussion when we've looked more for the evidence to inform that, because on this webinar, we try to use evidence to really inform or make the discussions evidence-based, so to speak. Thank you so much.
Thank you, Dr. Maritim. As you say, vaccines continue to be a very interesting discussion, and I think we'll ask Dr. Maritim to even touch on this more and more as we go forward in the next webinars. There are a few other maybe just quick questions. AstraZeneca, currently it's after 12 weeks. Yeah. Someone asked, can we delay? Maybe someone traveled, has come back. Yes, you can. If you got your first dose, go for your second. We have data suggesting that even up to 6 months, if the immune response is even stronger. So if someone has to delay for whatever reason, which we don't encourage, but if there's been a delay, please still go ahead and get your second dose. Don't stop because you have delayed getting your second dose, okay? Something about oxygen therapy, and this I think was covered even during the oxygen series. So for those who may still have questions on oxygen, please go onto the website and download the oxygen series. We had excellent presentation from critical care specialists who reviewed a number of cases, so you can get some of those and go through them again. The issue of topping up nasal prongs for patients who are unable to saturate well, despite being on 15 liters via non-rebreather mask. So remember, a non-rebreather mask will deliver for you what 100% FiO2 basically. Does adding the nasal prong increase the flow? Maybe it does. It's very difficult to determine whether it will. If a patient is on 15 liters and is not doing well, and you have no modality, please remember one of the sessions we had was around early referral of patients. So if you know that your facility cannot take care of a critically ill patient and your patient is already not doing well on 15, don't wait 3 days later when the patient is dying. Remember, early referral may save that patient. You want to refer that patient to a facility where they can take good care of them. It's very important as clinicians that we identify what our limits are. If I cannot take care of a patient, let me not hang on to that patient. Let me transcend them to the nearest facility that can take care of them. Sometimes in that process of transfer, you may end up doing whatever it takes to add your oxygen flow, but you really cannot monitor and you have no guarantee that now you're delivering 17 or 18 liters of oxygen. So if you can't take care of a patient, if you can't intubate or offer higher flow delivery of oxygen, then refer that patient. If your patient is on 15 liters and you're not saturating well, it is time to move on to the next delivery device, either high flow nasal cannula or an NIV. And if you're unable to do that, then it is time to intubate that patient. So it's important that we do not delay adequate delivery of oxygen to patients who may need it. Don't know if there's another question any of you may have identified that we need to answer. There's a question on pirfenidone. Pirfenidone is one of those that a lot of our colleagues, especially the chest physicians, have had more experience using it because it's used in patients with other lung fibrosis. It's been brought in not because we have so much evidence about it. So as time goes on, it's something we'll keep reviewing and maybe get back to you on the evidence around it. Someone says they've had 2 patients die on remdesivir infusion. Is this a known adverse event? Is death is probably an adverse event of anything under the earth. So I think you still need to go back and review. This patient was being given remdesivir. What was their clinical status? How are they oxygenated? Do you have a blood gas at that point? Could they have had a clot? You know, you have to review the patient wholly so that you know what could have been going on. Okay. All right. I think, do you have anything else any of you may want to answer? Well, someone on chemotherapy who gets COVID-19. We've had quite a number of patients with cancer who get COVID-19. Dr. Nyukuri, may have a comment for that?
Yes, for a patient who's on chemotherapy and who gets COVID-19, realize that this patient has 2 conditions. One is the primary malignancy, and number 2 is the cancer. So either of them can actually and will affect the patients. I've seen patients who are on chemotherapy who got COVID and they had asymptomatic COVID. So the only reason why you admitted them was for isolation until they completed the isolation period, then continued with the chemotherapy. And then there are those who actually got severe illness that even prevented them from getting chemotherapy. So we had to address the COVID-19 first and then stabilize them before they were able to continue with chemotherapy. So management is individualized and it will depend on the patient.
Thank you, Dr. Nyukuri. I think we can stop at that point. Remember, we have posted the link to the guidelines of the MOH website. If you click on it, it takes you right to the guideline, but you need to click on it before we close the session. So if you haven't downloaded, please do. Please share it with as many people as possible. Please support the facilities around you. Please check that they're doing the right thing. Please ensure your public facilities are working well so that patients get care when they need it. And we thank you all for the incredible work that you do taking care of patients in the country. I think with that, today we finish early. Today is a good day. We are finishing early. Thank you all for joining in. Thank you, Dr. Kuria, for joining us throughout this session, for the incredible words of advice that you gave us at the beginning. We appreciate the senior MOH leadership for all the support they have given. Thank you, Dr. Nyukuri and Dr. Maritim, for an excellent case presentation. I think people have learned so much from it, and there are a lot of good comments coming on from that. So with that, I think we'll close the session. We wish you all a very good weekend. Bye.